discussed some thoughts with regards to cardiology basics and things across the cardiology spectrum, recognizing for those of you who don't work in the cardiology space, we have so many subspecialty practices within cardiology. And so, and I was on the 2020 competency paper for general cardiology as written by the American College of Cardiology. And I will tell you that it's quite the specialty to tackle when it comes to all this. So hopefully, as we kind of march through this, you'll see the different topics in heart failure, in EP. This is kind of, I think, bread and butter for most cardiology practices is what I'll cover today, is the management of coronary artery disease. So I guess we'll move forward. I am Viet. I'm in the cardiovascular research department at Intermountain Medical Center. Leslie and I are part of a academic clinic, which is the cardiac care clinic, but we also have broken out into some subsections there, and we have a preventive cardiology clinic. And that's kind of my first love is preventive cardiology. So when we think of the management of coronary artery disease, one of the things I want you to think about is really, is this what's in the pipes, right? We have to kind of think about what's lurking underneath, and all the diseases kind of lead to it. And I'll just say that most everything rolls up to coronary artery disease. It's just, I'm not I am biased, but as we look at metabolic disease, renal disease, as we look at, now called metabolic non-alcoholic steatohepatitis and fatty liver disease. So we kind of have to think of that. And now I do have some conflicts of interest with regards to just overall, I'm an ad hoc consultant. I need to update this. I do have a research grant from Janssen, but I'm a consultant for Novartis, Pfizer, and Amarin as well. And those are just ad hoc. I serve as a consultant. There's, not being paid to do this or anything like that. And then I am part of multiple clinical trials. So really the objectives today is kind of outline the pathophysiology of coronary disease. I know that feels basic, but it gives context to coronary artery disease management. And so really reviewing that, summarizing the risk factors associated with atherosclerotic disease. I feel like we know those, but it's nice to just review them quickly. And then the modifiable factors, because, we can't modify age in particular. We wish we could. And sex kind of gets set in as well in terms of male and female and in terms of some of those factors from the very beginning. And so then there are the modifiable things. And we'll discuss acute to chronic management of coronary disease. I think that's helpful because we have a lot of crossover amongst our two specialties of cardiology and nephrology. So then we'll kind of review some of the potential acute and chronic sequelae. But as I've been building this, I've thought a lot about some of the newer therapies that cross over into both of our spaces, but that we should, I'm giving you license to both sides really to go ahead and treat the cardiovascular risk, whether that's kind of starting in the renal space or metabolic space, or it's starting in the cardiovascular space. These are patients. They're not just kidney. It's not just a heart, it's a patient. So we should think about those things. So kind of to start us off, what is the following, which of the following is part of the pathophysiology of atherosclerotic cardiovascular disease? And just, these are kind of like easy answer stuff. Is it accumulation of plaque in the walls of the arteries? Is it blood clots? Is that cardiovascular disease, the constriction of arteries due to spasm, the presence of cholesterol crystals and plaque? Or is it, perhaps all the above? What is a modifiable risk factor for coronary disease? Here, is it age? Is it family history? Is it high blood pressure? Is it all the above? And I think, again, if we can change the trajectory, then that's modifiable. In patients with AFib, this is something that comes up a lot. And I think in the general cardiology space, it's important because we run into this with our EP partners and there's a lot of crossover with AFib and stable coronary disease. But I bet our nephrology partners are also running into this also. But how do we manage the antithrombolytic therapy? So is it aspirin just alone, 81 milligrams? Is it aspirin and a P2Y12? Is it aspirin, P2Y12, and oral anticoagulant? Or is it P2Y12 and an oral anticoagulant? or just oral anticoagulant. And it becomes important as you think, well, why not all three? And, bleeding and the burden of pills and money, it's something we have to think about. And then which of the following is not a risk factor for atherosclerotic cardiovascular disease? High cholesterol, high blood pressure, diabetes, regular exercise, smoking. Okay, so I think it's important that we've got papers that describe what an MI is, what a myocardial infarction is, and they're not all the same. There's type 1 through 5, but I like this GIF because not all wheels are appropriate to what you're using it for. Here we've got some interesting folks. A little child probably is missing their favorite toy here, and then of course you kind of have a skateboard-esque like vehicle. And my favorite is, of course, the cat run wheel. So just recognize that not all MIs are the same. And so let me just focus on two, the top two, and mainly the most classic, which is what we think of as MI. So type 1 is a spontaneous MI that's due to atherosclerotic plaque rupture. Okay, these are your STEMI and non-STEMI from an atherosclerotic plaque. Now you can have some dissection as well that's part of this, but typically that kind of falls into the next grouping here of type 2. And if Sid were on, this is his Sid Biggs. This would be his main gripe with most anyone that calls a type 2 an NSTEMI, and it's not. It's demand ischemia. You can have infarct with this, but it's not a STEMI or NSTEMI. It makes a difference because of management. If someone has a coronary artery spasm, or they have a coronary embolism, or they have a dissection, those don't require statins. It's managed differently when it's not atherosclerotic in nature. So then as we move forward with acute coronary syndrome and chronic or stable coronary disease. So you kind of think about this from a standpoint of, to the far left here, I think we've all run into this, a little bit of congestion on the roads, but it's not stopped. People are moving. You're not as fast as you want to be. But as opposed to maybe an NSTEMI, where maybe it's not a full occlusion, it's starting to become it, and there are parts that are not moving, and you're starting to get infarct down the road, or you're not delivering the right, I'm not getting my Amazon package, etc. And then finally, we've all been in this, where that one car accident has led to 2, 3, 4, 5, and then everyone just stops and gawks or just can't go anywhere. And this is your kind of typical STEMI. So what are the, acute tools of the trade? This, I did a water heater swap out, and oh my gosh, it looks like this, the pipe on the left. It was so gross. But nonetheless, these are the kind of things that are happening. And as we think of a plumber, these are their tools, right? They've got this high jet pressured little hose thing you stick down there, and as you put water in it, it starts to open up, and then it sprays a jet down below. And then, of course, you can just kind of use this little plunger type whisker thing. But, as we come to, of course, the cath lab or the OR, we think of this occlusion. We have to open it. So this is nice to be able to see this. I mean, this is a 90% blockage in, the LAD. And you can clearly see that. And here's post-stent on the right side, where now you have this nice good flow through there. But if you're careful and you look at this, there's actually a bifurcation lesion right here as well, that it just drops off quite a bit right after where those coronary arteries branch off. And so that will probably something that they have to address. This is left circumflex, and it's down around the mid portion. Alternatively, of course, if they have multi-vessel disease, then perhaps stenting everything and getting a full metal jacket is not a great idea. And we see in folks that have diabetes, bypass makes a lot more sense. And I love to use pictures like this. It makes a lot more sense for my patients when you start to describe what a single bypass is versus a double. And then here, where someone's got, a Y graft, and that makes this a triple, and then a quadruple, where you have multiple. But it's really often just branches off onto the same artery. So it's not like you did quadruple epicardial lesions, or not arteries, because there's really only the main three, but different parts of them, and then how many grafts that involves. So it's important for us to recognize that and know that the more grafts you have, the more chances for crap to happen. In the same with stents. So here, I think is important to realize that when we think of systemic disease, I mean, look at the aorta in relation as 25 millimeters in relation to coronary artery, which is 3 millimeters. I mean, it's kind of a tenth of the size, right? So I say this because it's important. When you have peripheral arterial disease, something large enough to block an aorta or even a femoral artery, that same lesion that's built up in the femoral artery, boy, imagine, relatively speaking, how that will plug up the coronary arteries. So that's why we say when you find someone with peripheral arterial disease, they're 7 times more likely to develop coronary disease. But the reverse is not the same. If you have this 1-2 car accident on the road over here, well, on the freeway, it probably doesn't mean anything, but only on a 2-lane road, that's going to block the road. So then, hence kind of comes to this GIF here where you see the hamster that's me anyways, trying to fit into a pipe. But here is even more devastating when, whoops, I didn't anticipate how low that bridge was, and crap happens. And so you kind of think about, PAD as really a harbinger of bad things to come, because you've built enough plaque to plug up a large artery. This thing on the right here, that crap's going to happen. So be aware of that, especially in our renal folks. Nephrology, you've got a lot of diabetics that are running your way. They've got PAD. They've also got coronary disease, most likely. Okay. So here, where does coronary calcium fit in? And, this is when we think about statin eligibility, it's like, who's at risk? So who should be on a statin? These are the 2019 guidelines. And I think it's important to think about coronary calcium. I do it all the time in my preventive cardiology clinic. And I think it's very helpful. We're running a full-scale 9,000 person randomized trial here called CoreCal. And what we're looking at is risk factors versus actually what happens when you know the person has or does not have disease. And it's very specific to the individual. Whereas when we think of the risk scores, I mean, it's so binary. Do you have hypertension or do you not? And if you have hypertension, there's no discernment between 140 systolic versus 200 systolic. So, it's just yes, no. Same thing with diabetes. Do you have it or do you not? And then it doesn't discern between diabetes with an A1C of 20% versus, 7%. So it's really rough estimates, whereas coronary calcium is the direct plaque that's in someone's heart. Now, I want to show you this. The around the green, calcium 0 doesn't mean 0 plaque. It just means that it's not calcified. So I'm very careful to talk to my patients that, calcium 0, we don't use statins, but the event rate is very, very low. Out to 10 and 15 years follow-up, the event rate's maybe 1%, which is just phenomenal. Even in the presence of this soft plaque that just hasn't calcified. There's something about calcification. There's micro injury, micro trauma, inflammation, and those are the folks that, just imagine magma underneath here. We've got magma, but we don't have volcanoes because there's no eruptions. So while it exists below us, we don't have a volcano. And if you have a volcano, then you're probably in the area where eruptions will occur. And so here is calcium greater than 100 or being in the 75th percentile. Look, you should not be 35 years of age and have coronary calcium. That is way too early. And I'll tell you that the only patients that I see with this are familial hypercholesterolemia, where they are exposed to very high cholesterol, 200 to 300 LDL cholesterol since birth, since conception, really. And so their cholesterol burden has been for a long time, and they've developed coronary calcium. So here's where it's important, right? So again, on a Kaplan-Meier curve, on this side over here is event rates, and look how far out, 8 years of follow-up. So when we look at folks in 300 range, that's 13.3% event rate by 8 years out. And by the way, that's close to what we see with someone that's had a STEMI. if we started here and said time 0 and they had a STEMI, this is what it would look like actually in the next 8 years. So these people with CAC 300, they're just a volcano waiting to happen. Meanwhile, as we look at CAC 0, it's, I said 1%, it's 1 to 2%. And that's throughout the next 8 years. And by the way, that's even when they have other risk factors, like they smoke, have hypertension, have diabetes, etc. When you have a CAC 0, even in those risk factors, it's pretty indicative of someone that's has a low trajectory. Now, if you do it at 30 years of age, for most of your patients, you wouldn't. But if you did it there, you would expect a 0. It's like asking someone, let's do a colonoscopy on a 10-year-old. Let's do, breast mammogram on a 10-year-old. It doesn't make sense. You have to focus into the area where you would expect to start seeing risk. That's when you do coronary calcium. So here's an ABI, if you've not done one or you've not heard of this, ankle brachial index. I'm not being patronized, just sometimes we go through and learn things and these smaller items we forget. But in any case, here's mild PAD. So you should have a 1-to-1 ratio between the top and bottom cuff readings. But as it drops down in your lower extremities, that's indicative of some type of flow limitations. And so when you drop below 0.9, now you have this flow limitation. It's probably atherosclerosis. Here, as you get to 0.51 to 0.69, it's actually starts to become critical limb ischemia, but we're calling it moderate PAD. And then finally, less than or equal to 0.5. You're searching for trouble, and probably amputations next. So we have to get to people sooner. We have to be screening folks and addressing these risks. And here, I think it's important then, based on ABI, or actually this is just based on known or asymptomatic and symptomatic PAD. So when you have someone that's asymptomatic, so you've done an ABI and it's abnormal, but they're not feeling claudication symptoms, it's a 26% event rate in 5 years. I mean, think of that. That's 1 in 4 that are going to have an event in the next 5 years without symptoms. So that's why we do screening for PAD in the right populations. I mean, symptomatic PAD, they're kind of screwed, right? 40% event rate in 5 years. That's horrible, and we have to do better. Here's from an ABI standpoint, just looking at ABIs regardless of symptoms. And what you find is that, again, ABI that's abnormal, it's less than 0.9, but it's greater than 0.7, still 1 in 4 having an event by 5 years. Okay. And so I'll skip this. This was kind of my talk with regards to coronary calcium screening, with regards to screening for ABI, et cetera. But it's really, risk factors. Where do you find the existential question is where do you find, apple trees in a forest or where apples grow? And so obviously, you're looking in the orchard, and that's kind of what I think is helpful about screening with either using risk factors, coronary calcium, ABI, et cetera. That's where you're going to find the most likely places for coronary disease, or in this case, apples. And it's no small surprise that when we look at risk factors, then here's smoking, diabetes, they all center in areas where high prevalence is. So yeah, okay, maybe the orchard for coronary disease is down where there's most smoking, most diabetes, most elevated cholesterol. But really, it's across the nation. It's getting worse with increasing obesity. But I think it's important to know that despite all of that, the largest portion of events showing up for their first MI have 0 risk factors. Let me say that again. The largest portion of people who are showing up for their first heart attack, 0 risk factors. So we're still missing a considerable number of people. And we've written, we've published on now NSTEMI and STEMI in what we call SMRF. The standard modifiable risk factors, SMRF. And in the absence of those, you still will have STEMI and STEMI, about 1 in 4, 1 in 5 show up to our ER without any traditional risk factors. And what we found is coronary calcium probably would have picked them up, and we could have applied therapies much sooner. Okay, so you just have to recognize that risk factors are they're helpful, but they're not the end all be all. We have to be careful about thinking of these risk factors as monolithic, that somehow, and you probably learned this, I definitely learned it about 24 years ago, is that somehow diabetes was equivalent to coronary disease. It's not true. It's not true. It is not equivalent to coronary disease. And we did the Factor 64 study here, where a good 30% of our type 2 diabetes, type 1 even, and these were years. I mean, some of them had 15, 20 years with A1Cs and 13%, calcium zero, and events also zero. So you use it as a way to find the orchard and do further thinking. We have to use our brains on this. So you have a patient with atherosclerosis. Okay, so it's talked about screening and all that, but now they have atherosclerosis, and what are you going to do at this point? So here, I'll equate the two: PAD, stable angina, claudication. Here's an NSTEMI with acute limb ischemia or, and then finally, what about the STEMI that comes up, or stroke or amputation? They have this. What are we going to do about it? So the secondary prevention, folks, avoiding a second event. I think this is helpful. I love The Office. Fool me once, strike one, but fool me twice, strike three. I mean, it's kind of like that. To me, anyways, if you've had an event, I just don't want to be fooled the next couple of times, because death is really is high on the list of symptoms, and you just can't walk back from that if you have an event. And then this is not my cat, but generally speaking, this is what my cat would do. Okay, and we know this. I mean, I'm speaking to APPs. We're just part of that team-based care, but we do have to make sure that we leverage the team. Remember that the patient's at center, and we have to circle the wagons to make sure they're getting the care that they want and that we know they need, and translate that appropriately so they recognize that it is something that will be helpful for them. Here are the risk factors. Again, I think all of us have heard these: hypertension, smoking, and I'm sure that some of our patients are doing that at that level. Dyslipidemia, diabetes, and then family history of coronary artery disease. These are risk factors. Age and gender, I didn't have on here, or age and sex, I should say, I didn't have on here, but we know these. These are family history is not modifiable, but the top four are. So as we kind of think about that, I'm going to kind of shift a little bit and start with antiplatelets, because you probably would have thought, oh, it's VIA, you'll start with lipids. But I think here it's important to recognize that plaque presence means potential for rupture or thrombus. And what I mean by that is, we don't have rupture in areas around that endothelium where there's no plaque. It's where that plaque sits underneath the endothelium that's most likely to rupture. And so that's why when you think of the Esprit trial, the Ascend trial, the JP3 trial, all of these were high-risk primary prevention trials with regards to, do we use aspirin or do we not? And you've probably heard the USPTSCF, that I screw that name up all the time, but they've oh, we don't recommend aspirin in primary prevention. And I think for the most part, that's probably true. There are only certain cases where I would say primary prevention, you would use aspirin, and that would be with presence of coronary calcium, in particular when it's 100 or greater, or they're in the 75th percentile, because now they have atherosclerosis and there is chance of rupture. So I think the adaptable trial, which we were a site here, asked 81 or 325. You have to ask that. It's a comparative effectiveness trial, because we didn't know, actually. And honestly, what it demonstrated was that 81 milligrams is the same benefit as 325, just less bleeding. Now, if they had gone longer, we might have potentially seen some benefit, more benefit with 325, but we're not sure. P2Y12 inhibitor, so clopidogrel, prasugrel, ticagrelor. These are important to have. And the question always is, do we do it both? Dual antiplatelet. Is it both aspirin and P2Y12, or is it, both for a bit and then do you drop one? We'll talk about that. But you can kind of see on the left here, when you have this stent structure, this foreign object, this is why dual antiplatelet is so important, at least within the first month, then 3, 6, 12 months, depending if they did it electively or they had it as part of acute coronary syndrome, is when you want that dual antiplatelet mechanism. So when do you go to aspirin or P2Y12 alone? Oh, sorry, I'm just looking there at the chat. But so, in my practice, and hopefully I'll show you the data, P2Y12 alone, if you're doing chronic stable coronary disease, that makes a lot of sense, and the data backs us up with that. But certainly it depends on when the patient presents and what's happening at the time. So when we look at this is the master treatment algorithm for P2Y12 in patients with coronary disease, and they start with DAPT. So of course the top is coronary disease. And then there's, like I said, it makes a difference. So if you have stable ischemic heart disease or if you have acute coronary syndrome. So let's look at the stable ischemic heart disease side. And you can see on the far left here is the timing. It'll be 0, 6, and 12 months, and then beyond that. And so if you have stable ischemic disease, I had a heart attack like 3 years ago. I've not had another one. What do I do? So no, if they've not had the third component of that is maybe they had a little bit of chest pain, had a positive stress test, no heart attack, but they end up just being treated medically or getting a PCI or bypass, etc. So here, there's no real benefit in dual antiplatelet therapy. That's true. They're going to have more bleed, and there's really no reason to be on both at the same time. But if you're status post PCI, if you've had a stent, and I would argue, angioplasty kind of falls in there, but here they're specific to bare metal, which we don't use often anymore, and then drug-coated stents, drug-eluting stents. You can see that for class 1, at least a month with dual antiplatelet, and clopidogrel is part of that. And then afterwards, the question is what do you do? Is it aspirin or is it P2Y12? Here with drug-coated stents, at least 6 months. This is stable ischemic disease, by the way. It's an elective procedure, and then you want 6 months for placement of aspirin and clopidogrel after the stent. And let me just tell you why. So remember that a bare metal stent, it's bare. You're endothelializing across that stent. And historically, what happened was with bare metal stent, 25% failure rates was because of too much scarring, too much endothelial lining across that stent. It was too thick. And so it was kind of like, keloid scar, but inside the coronary artery where the stent was. And that would lead to in the stent, restenosis, re-narrowing. And so then we developed these drug-coated stents that had a chemotactic agent slowing endothelialization through that stent. With now first, second, now third generation of drug coating, which has allowed us to use less and less, P2Y12 inhibitors or DAPT, and it coats more smoothly, etc. But that's why you have to keep someone on DAPT for a little bit longer, because that endothelialization has slowed down. We want it to happen, but not to scar excessively. And but you leave this struts open for clotting if you don't have dual antiplatelet therapy. Now with bypass, really it's like, okay, whatever. You could use clopidogrel by itself or aspirin by itself. You don't really have to have dual antiplatelet therapy. But then once you get to the 6-month mark, what else do you do? Do you go aspirin by itself, or do you go clopidogrel by itself, or just kind of keep them on both? And you can see that class 1 is different here. 2B, it's like maybe it's reasonable to continue, etc. But in bypass, it's like you could just maybe clopidogrel by itself or aspirin by itself, but not both. So now as we get to the acute side, this is, NSTEMIs and STEMIs. Well, if you're doing medical therapy, and that happens, by the way, there are folks that come in NSTEMI, they don't have any more chest pain, they're doing well, and they might not go to the cath lab. I know it sounds weird, but there are folks that are just treated medically, and that's fine. Then, they're on at least both for the duration of 12 months, because this is the acute coronary syndrome. It makes it very simple, really, whether you're using lytics, whether you're doing, PCI with bare metal stents or drug coated. Anyone that comes in with an acute coronary syndrome, guess what? Dual antiplatelet therapy. And I think that's kind of been the model. but hopefully I'll change your mind a little bit. You don't have to worry about this, but we just had the reduced AMI study reported out at the sessions this weekend at American College of Cardiology. Intriguing. Ticagrelor for 30 days and then just by itself for the rest of the time. This is acute coronary syndrome. And so it's changing the paradigm of how we do things. But for now, you can feel comfortable that in acute coronary syndrome, by guideline, this is recent guideline, it'll change in the future, that dual antiplatelet therapy. And then after that, it's like, so we continue it? Generally, I don't. I then move them to P2Y12 alone. But some of the guidelines still kind of have a holdover for aspirin by itself. I like P2Y12. It has better efficacy in terms of MACE reduction and less bleeding than aspirin, and that's why I use it. So here's, at the full glance here. Then so we kind of come back to this, okay? Aspirin or P2Y12. What do we do after that 12 months? Or what do we do when we go to single antiplatelet agent? 1996, hopefully everyone's been around since then. I was graduated from high school in Houston. But in 1996, back as far as that, we showed clopidogrel was better over aspirin. And yet it just never really kind of took off in trials since then until 2022, host exam affirmed the data from the Capri trial that P2Y12 was better over aspirin as monotherapy. Now, ultimate DAPT was just reported out. I said reduce AMI. I'm sorry. That's the beta blocker one, and we'll talk about that later. Ultimate DAPT was reported here at AC, well, not here, but Atlanta at ACC. And post-MI ticagrelor monotherapy versus DAPT, aspirin and ticagrelor, after 30 days. So they got to the 30-day mark, and if there were no further events in that time, they were fairly stable, which most of our patients are at that point, then we showed that ticagrelor was better than DAPT, meaning it had the same efficacy in reducing MACE events without the added risk of bleeding, and that's where it wins out. So guidelines are still geared to aspirin 81 though, and I think for me, I have no problem switching to clopidogrel alone, or if they have the money, ticagrelor or prasugrel. Okay, so here, what if they have AFib? Let's make this further real, because most of our patients will at some point, right, like a quarter of the population over the age 40, which is many of us here. Once you hit 40, you're higher risk for AFib, but you're also higher risk for coronary disease. So let's look at this side first without anticoagulant. This is chronic cardiovascular disease, and we looked at this. This is essentially the same. They say aspirin, I say P2Y12. But if they've had a ACS with or without prior PCI, again, made it simple. It's DAPT. And then for people who were at low or moderate risk of bleeding and just had elective PCI, not acute coronary syndrome, there's this kind of moment where you can switch to single at 6 months. And then if they were high bleeding risk, you'd shift them sooner at 3 months instead of 6. Okay. It's like, well, this and then that, and then this and then that. It gets a little complicated, and you just have to think about it. This is a great algorithm. But boy, when you have AFib and you need oral anticoagulant, it becomes so much easier. And I say that knowing that this still looks not very easy, but it is. So if you have AFib with chronic coronary disease, just throw out antiplatelets. No need for aspirin or clopidogrel or anything else. DOAC. That's it. Okay. And then what if they do have a PCI though, and it's chronic, coronary disease? If they're low or moderate risk of bleeding, and they get a stent, then you're going to be on all three for the first month. So yeah, I know, Eliquis daily or rivaroxaban plus a clopidogrel plus aspirin, but about a month. And then after that, then you just go to the DOAC and P2Y12. And then at 6 months, you can just transition DOAC by itself. I mean, it's nice. You no longer have to kind of think through this, because the data on the DOACs and cardiovascular disease as well as AFib are just fantastic. What if they're high risk of bleed? Well, you're going to transition them a little bit sooner maybe. So do you have them on all three for the month? Maybe. And then after that, you can switch to DOAC and clopidogrel, but do you have to go the full 6? Mm, I think that transitioning to a DOAC earlier would be fine. I say that imputing some of the data, but it's incredibly simplifying when I don't wish people to have AFib, but if they have any reason to be on long-term DOAC, that's it. You've got the easy button. Okay, so oh, I guess I spoke without doing this, but I'll share my slides so that you have access to them. In any case, I just kind of went through the same thing. Sorry, but now I have cool animations. So there you have it. So again, all together. Um, Dr. Knowlton, Kirk Knowlton, always warns me about animations because sometimes you forget. And then, of course, that would have been cooler to have it during what I said earlier. So let's kind of think through a case. Here's a 55-year-old man returning for annual follow-up. He's had an MI at the age of 50. That's kind of early, right? Two vessel bypass, so it was severe at an early age. And he has paroxysmal AFib. His mom had an MI at age 55. You're like, familial hypercholesterolemia kind of antenna should be raising here. He has a sister alive and well. He's a florist, single, lifetime non-smoker, lifts weights 2 to 3 times a week. And then he's on clopidogrel. So yay, rosuvastatin 40 milligrams, ezetimibe 10, biweekly Repatha. He's on the lipid stuff, right? He's probably seen me. I don't know. Metoprolol succinate 50 milligrams, and then sublingual nitroglycerin 0.4. I'll vitals, nothing to kind of shake a stick at or write home, other than BMI, 29.5. We really should be thinking lifestyle and losing some weight here. But his labs here, total cholesterol 200, triglycerides 110, HDL 42, LDL 50, A1C 5.5. What are you going to do? What are you going to do to simplify this? Because he has paroxysmal AFib. So here I would say, okay, paroxysmal AF, what's the antithrombotic regimen? Well, in this case, do a CHADS VASc score, CHADS 2 VASc, and he will fall in the, again, men 2 or greater, women 3 or greater with the CHADS VASc score, and he'll fall into this. Because of all the risk factors that he has here. And so I would initiate oral anticoagulant and stop the P2Y12. I can cover both diseases of coronary disease and paroxysmal. We'll simplify this. And then just, again, the education, make sure that you let them know why and then what to watch for. Okay, so what about beta blockers in those who have had an acute MI? I alluded to this a little bit with reduced AMI. It's been axiomatic. It's been axiomatic that everyone that's had a heart attack should be on a beta blocker, aspirin, ACE inhibitor, and a statin. Of course, I'm saying axiomatic from when I first started cardiology in 2004. So it's been 20 years. But in 2021, the recommendation really was changed, right? Instead of like indefinite lifetime, it was after an AMI event, acute myocardial infarction event, stop after 3 years if the LV function was normal, which is defined as greater than or equal to 50%. Well, in 2023, the guidelines that we just went through with DAPT and DOACs, they say reassess the beta blocker therapy, and if it's greater than or equal to 50%, at about a year that they've been on it or more, then maybe reassess and stop it because most likely they don't need it. But in 2024, the question becomes, what about right out of the gate? If they've had an acute myocardial infarction, how comfortable if their function is still 50% or greater at the time of this MI, you just not even think about having a beta blocker, right? Can you just stop it? Well, let me just go to the current guidelines. This is the chronic coronary disease guidelines. And I'll say that class 1 is that for people with less than 40%, less than or equal, use beta blocker therapy. That it's taken a hit. There's infarct. There's going to be this remodeling that's abnormal. And beta blockers help in that space, as well as reducing ischemia for the peri-infarct area around the site of infarct. You're trying to salvage some of that tissue. And then, another class 1 is when it's less than 50%. So the first one is like no brainer, less than 40. But what about less than 50? Same. Metoprolol, carvedilol, bisoprolol, great. 2B is here where they have not had a history of LVEF less than 50. It's a weird way of saying this. It's like a double negative. But if they happen to have a normal LVEF, but a prior MI, they're like, you could consider beta blocker therapy. Where it's not beneficial is when they've had no MI and their LVEF is greater than 50%. It's just not beneficial in reducing MACE. So there's a population out there in stable coronary disease without prior MI. Do not reach for the beta blocker, okay? But here, where the reduce AMI study was just recently reported, the question is, does long-term oral beta blocker treatment in patients with an acute MI but preserve left ventricular function, does it improve function? So they, or outcome, they chose the like, we think that it will be beneficial to be on a beta blocker for folks, even if they have normal LV function. We think that's going to win out over those that you don't use a beta blocker. So, oh, Leslie, we see your camera. So now the outcomes. Okay, so this is the outcomes of interest. Primary endpoint, secondary endpoint, safety. Really, it's a composite of death of any cause or new MI. That's the question. Does a beta blocker help reduce death, reduce new MI? And then all of these are kind of broken out a little bit. What they did was they took 5,000 patients and randomized to 2,500 in each arm. No oral beta blockade or metoprolol, succinate, bisoprolol. And then you looked at these primary and secondary endpoints. And just so you know the baseline characteristics, it's important to know that a third were ST elevation MI. These were not they had risk. I mean, this is STEMI, full occlusion in a third of the patients. And then some were on oral beta blocker therapy already at baseline. And so these individuals on this side had 12%. They just stopped the beta blocker on that side, whereas then you just added beta blockers to 90% of those folks. 65 years of age, and again, we're really bad at enrolling women. Okay, well, boom, no difference. Absolutely no difference if you just left them alone, no beta blockers, versus if you decided, hey, I think this is going to reduce death or MI. They just sat right on top of each other, those lines. And I mean, look at the p-value. I mean, it's just basically, yeah, this is going to be the same. And even though that looks like the hazard ratio was like, oh, maybe 4% benefit, it crossed the line of unity. And so it's just kind of like, let's roll the dice and see what happens. Well, when you roll it, it's neutral. Okay. So I just want to stick that in there because this is, beta blockers from a quality of life perspective, it's problematic. So here, let me just address the hypertension. It's always striking to see what happens when blood pressure or any pressure gets a little out of hand here on the left. And so think of GDMT as guideline-directed medical therapy. And really the blood pressure goal is not less than 140. It is less than 130. And it just, I think all of us here understand that as nephrology and cardiovascular, but it's pretty interesting when I talk to primary care, what they think of a blood pressure goal of less than 130. So let me just walk through this because this is the hypertension categories when please don't practice JNC 7 or 8. It's malpractice and people are dying. I just say that up front. But this is what happened, right? From JNC 7, 8, same thing, to 2017 is those that were pre-hypertensive are now truly appropriately stage 1 hypertension. Those that were in stage 2 but were counted as stage 1 appropriately, their risk, DEFCON 1, which is the highest risk, versus DEFCON 5. We hear DEFCON 5 all the time. But it just moves up as to really the mortality and sequelae that occur. And really, this is it. I mean, it's the easy button. It doesn't matter if you're a general population, whether you're older, like me, whether you have diabetes or chronic kidney disease. The goal is less than 130 over 80. None of this crap that we saw in JNC 8, again, malpractice. And here, it's a much easier and simple rule to follow is let's get them underneath stage 1 hypertension. Okay. Lifestyle first, foremost, and always, but it's don't prescribe it as if it's this drudgery, because honestly, and having run on the treadmill this morning, I don't know what's longer, a microwave minute or a treadmill minute. But I think it's important, as we discuss lifestyle, it's not work you do to become healthy. It's just part of what you do to make activities enjoyable, make the exercise enjoyable. And you should do that with others. It should be something that just happens and that you plan for and that you're intentional about it. But don't make it drudgery, or they just won't do it. Uh, you know, oh, uh, Oh, okay. I didn't know if Leslie had a comment. Physical activity recommendations in coronary artery disease. This, it hasn't changed. This is the American Heart Association. It's pretty easy, 30 minutes most days, or 5 days, to get at least 150. And I tell people it's okay to break that up. You don't have to do 30 minutes in a row. Cumulative, the data is consistent that cumulative, 3 10-minute sessions, 6 5-minute sessions. As long as you're out, you're getting your heart rate up, you get your 150 minutes in a week. I like this one because it includes high intensity exercise, where we do get people to get out and do resistance training. I think that's something that we don't do enough of in terms of recommendation, and we can walk patients through that. Here, it's oddly enough, it's a little bit different when it's just for targeting lower blood pressure and cholesterol. I would say just, one of the former 2 slides there are just as helpful, but you can also do this. I tell people consider the FIT principle. So frequency, intensity, time, and type, and really just change 1 or 2. I mean, there's no reason for people who've never worked out to do like 5 days a week, and then like increase the intensity the next day, or increase the time. Just, I tell them, look, do what's comfortable, test it out, see what you can do, and then start adding slowly. But just one of those things, maybe something else, but don't add all 4 or modify all 4. It's really difficult. And pain is a negative feedback loop if they're sore the next day. Pharmacotherapeutic. So I think, what do you start with? First line or condition driven is really the answer. So regardless of the underlying condition, just start with the agents that have the best data for clinical outcomes. Not all of them do, or not all of them have data across all things like diabetes or coronary disease, stroke, etc. So the primary agents we use in hypertension, these. I mean, I'm speaking to a group that uses these often, and so and I don't know that we have to go over the mechanisms and stuff, but I like the order also of how to start, unless there's something that comes up first, like coronary disease or diabetes, that would make me do RAS inhibition first with ACE or ARBs. Heart failure, of course, you'd go to ARNI, etc. But if if they have heart failure, please avoid diltiazem and verapamil. That is known to worsen and potentially be lethal for folks that have heart failure with reduced ejection fraction. Okay, so here, if they have stable ischemic heart disease and happen to have angina, then of course the GDMT is ACE ARBs plus minus beta blockers. Angina, think of amlodipine. It's an anti-anginal, or felodipine or whatever have you in that space. And then I don't know why I have thiazides in there. Sorry, I need to fix this. But beta blockers then when they have angina. So if you have an amlodipine and a metoprolol and they're still having symptoms, and then you add IMDR or isosorbide mononitrate, it might be time to reassess whether they need some type of angioplasty or revascularization. Okay. Post ACS, again, LV dysfunction, if it's present, beta blocker. And then, plus minus ACE ARB. If they have normal function, then just go ACE ARB. And then HFrEF, you can see there's now the 4 pillars of therapy. CKD, I added here. I'm speaking in nephrology. Consider SGLT2s a non-steroidal MRA, which is finerenone. In this space because of the data. And both of them, by the way, while they don't have an indication for hypertension, they both modestly reduce blood pressure because of their mechanisms by, I mean, I've seen as much as 5 to 10 millimeters of mercury. So, so consider it. And then diabetes, all of them are first line medications unless they have CKD or coronary disease, and then you modify. So here's another case. 63-year-old woman presents for follow-up. She continues to have stable angina, climbing 2 flights of stairs. She had an MI at the age of 60. Again, it presented pretty severe with 3 vessel, but she has, normal LV function. Medical technologist. She's a former smoker, doesn't smoke now. She's clopidogrel 75 milligrams, Rasuva 40, ezetimibe 10, valsartan 80. And then you have her kind of on this PRN nitroglycerin if she needs it. Blood pressure, though, is 138 over 80. And so here, what do we think? She's got stable angina. She's not on any she's on valsartan. And then, what can you add? What do you want to add? Any thoughts before I kind of share my slides? You can put it in the chat or come off, or if you want to wait, I can just go to my slides. Okay, I'll go to my slides. So here, stage 1, she's greater than or equal to 130, greater than or equal to 80. And, here you could use ASCVD, don't use it. She's already got coronary disease, really. And so I would elect to increase valsartan to 160 and consider adding amlodipine. I think valsartan is not an anti-anginal, but in my mind, you probably could just go to amlodipine first and just add 5 milligrams there. But the valsartan is such a small dose, and I do want to protect her kidneys. I think that she'll be okay with both of them. But if you push me on it, I would use the amlodipine 5 milligrams first as an anti-anginal. If she needed it. Here it's stable angina, and I guess the question is how much angina are you having? Can we reduce it? And then that's when I would probably use amlodipine first. But I think valsartan 160 and then adding amlodipine next will be helpful. Just remember that large swings in blood pressure, even in the normal ranges, if you achieve 120, she may still feel orthostatic because that's an 18 millimeter mercury drop. So just kind of think of lipids, and I'll throw this in here. This is the La Rosa. Treating to New Targets was presented in 2005. It's one of my first ACCs that I attended as a cardiology PA, as a PA, period. And I think it's interesting to think of the 4S trial. You think of simvastatin, and my goodness, they were like enrolling people that had a baseline of 190 milligrams per deciliter. That was the baseline enrollment. And so, of course, you're like, wow, yeah, if you drop down to 120 from 190, you're going to see a reduction in events. And they did. But then we thought, well, what about lower? So lipid trial, down. Yes. CARE trial. Yes. HPS. Yes. Treating to New Targets, which was this trial. Yes. So each time we went down, and by the way, in the era of PCSK9s, of adding bempedoic, of adding ezetimibe, the same. There just is no end to benefit as you continue to go down from wherever you were baseline. In statin versus no statin, for every 38 milligrams per deciliter that you drop, there's a 20% reduction in MACE in the first year. You keep them on statin and it goes to 25%. What about intensive versus less intensive? Well, as you further reduce LDL cholesterol, then, for every 19 milligrams per deciliter, you get about a 15% MACE reduction. Finally, the bottom line is really get a 50% reduction if you can. But any change, dropping 50 milligrams per deciliter, you get about a drop in MACE by about 28%. So lower, better, and do it sooner. Secondary prevention, again, greater than 50% from baseline, use high intensity statins. Here they are, made the easy button. And then AHA 2018, the second goal was actually a threshold, was LDL cholesterol less than 70. First minimum goal is to drop from wherever they are by 50%. And then the updated 2022 expert consensus guidelines tell us less than 55 is really where we go for very high risk. And it's not hard to get to very high risk. If you've had one event, have diabetes and hypertension. If you have one event, have hypertension, CKD. If you're one event, you're 65 or older and have hypertension, you're there. Most of our patients are very high risk. So here's the key takeaway: statin first, reduce by greater than 50%, add non-statins if the thresholds are still above, and then don't wait 3 to 6 months. Guys, you reach nadir by 2 weeks. So I usually test between 3 and 5. but 4 to 6 weeks is what's in the guideline. So don't wait 3 months, please. So back to kind of a case. So 66-year-old had an MI, age 63, has had 2 stents, had type 2 diabetes. Here he's a former smoker. You can see his medications: clopidogrel, rosuvastatin, ezetimibe, valsartan, HCG, dapagliflozin, semaglutide, and then sublingual PRN, nitroglycerin. And as you're looking through this, okay, great, but this LDL is 88. And I'm going to throw in for my nephrology folks, UACR is 40 milligrams per millimole, and BUD an EGFR of 92. Okay, so I just wanted to throw that in because I think we see this, right? Well, what are you going to do? What are your recommendations here? Of course, this is the lipid portion of my talk. This is a very high risk ASCVD patient, had an MI, but also has type 2 diabetes and has CKD. Okay, so an LDL cholesterol goal of less than 55. Of course, lifestyle, of course. In each of my cases, that's what I say. But here, if you add Repatha to rosuvastatin and ezetimibe, if he's already at 88, you'll see about a 50% and upwards of 60%. And if you just do the math, the back of the napkin math, you're going to achieve 44 milligrams per deciliter. He'll make that goal of less than 55. And it's okay. You'll be okay. He'll be okay. In fact, there may be some evidence of plaque regression if you can get it to less than 40. Okay, but again, you want to have them check it. Here, I check in the 3rd week, so after the 2nd injection, and we then decide what to do after that. But often they meet goal with just that. Diabetes and coronary artery disease, the prevalence, I think it's important to recognize that the prevalence of diabetes is such in terms of when you have coronary disease, overall diabetes prevalence. There's really, quite a few people that either in the pre-diabetic stage or have diabetes itself. There's just a large range here. And then within the cardiovascular disease space, prevalence, I'm sorry, I said that wrong. In those that have diabetes, the prevalence of cardiovascular disease is 33%. Okay. And then, sorry, this is kind of a little bit opposite. In coronary disease, what's the diabetes prevalence? Hopefully that'll make more sense here, that we have a lot of people with coronary disease with metabolic disease. So if you have someone that has coronary disease, primarily, they have metabolic disease. If you're treating someone with diabetes, about 1 in 3 have cardiovascular disease, either diagnosed or not. So coming back to this, what are the therapies? What are the pillars of therapies? And glycemic management, of course, blood pressure, lipid, and then agents that have a kidney benefit as well as a cardiovascular benefit. So this is coming from the 2022. I should have updated 2023, and I think the 2024 are out too. But really, if they have ASCVD, then it's early. It's early. You just go ahead and think GLP-1 or SGLT2. Just either or. I use both. I have no problems with combinations. And then if A1C is above target, then you add the other one if you haven't already. But I try to do it as soon as I can. I don't really care what A1C is because the benefit is cardiovascular and kidney. And I hope I can convince you of that in a few more slides here. So really, it's metabolic disease we're treating. We're not treating glucose. Please get that out of your mind. That's an insulin that's what we're treating is glucose. But here we're treating the metabolic dysfunction that's leading to glucose. Okay, so I would just want to make that clear. 50-year-old here, diabetes since age 30, has hypertension, MI at the age of 45. So really early here, 3-vessel bypass. And it was severe when it showed up. He's a non-smoker, clopidogrel 75, Rasuva 40, valsartan 180. And then he's on metformin, 1,000 milligrams, 2 tabs, Lantus 30 units, and on glipizide. So this is such a common presentation. I'm like, there is nothing there that's really cardiovascular benefit in terms of diabetes. And you'll argue, well, metformin. Leslie sits by me, so she knows I am not a fan of metformin. The data is just not there. So I will say she is not on any metabolic medications that are cardiovascular benefit. So what are you going to do? Because A1C is 7.5%. I'm not going to mess with the LDL. Blood pressure, we could do as well here. But I think if we add certain therapies, we might see that blood pressure drop. So here they're very high risk, ASCVD. Somehow I've got a little crazy in terms of everything that I wanted to add because very high risk, excuse me. So LDL cholesterol 65, I misspoke. This is someone that I would do something with the cholesterol. And so adding ezetimibe would get them to 52. Adding amlodipine, clofalidone, or metoprolol succinate, although I would not add a beta blocker in this space. Most likely, I would actually go ahead and do a combination here, valsartan 180 with HCT. I might even bump that to 320 and go HCT 25, and then decide after that what to do. Adding an SGLT2 or GLP-1, removing the, this is me. I know, Leslie, again, recognizing you're an expert in the endocrinology space. This is a preventive cardiology guy with no, direct endocrine management, but I would remove the glipizide and then start reducing as we add these on. And they're already like, usually the insulin folks are already pretty clean on following their insulin. And so I work with them very closely in that first week to say, okay, just let's do this appropriately. Don't stop things. Let's reduce as appropriate to keep you from having hypoglycemia. But it's easy if you just remove the glipizide first. And honestly, I would have removed the metformin, but I didn't want to be too controversial here, adding SGLT2 and or GLP-1. And then reassess. If they have a CGM, great. If they have blood pressure, great, etc. And then I would check that lipid within the next 3 to 5 weeks for me, but 4 to 6 weeks is reasonable. Okay, so sequelae, angina. Hopefully we've kind of thought that through. Surveillance with ABI, carotid, abdominal ultrasound, stress test. This comes up often, and for the scope of this talk, we won't address those. But now that we're coming to I'm overtime. Partly we started 10 minutes late, but this is something I want my cardiology folks to recognize. I think nephrology gets this. But look at the EGFRs, okay? So we kind of think of EGFR greater than or equal to 90 as, oh, that's great. And honestly, I have a few colleagues that are like, oh, greater than 60 is fantastic. So don't laugh at us, nephrology. But that's kind of, the thought. But look what happens when even at EGFR, which, we were like, well, that's way normal. Well, okay, no albuminuria. This is the referent number, by the way. EGFR greater than or equal to 90, no albuminuria. Boom, you start to have a 70% jump in cardiovascular death, 90% when you get the very high albuminuria increase. And that's with an EGFR of greater than 90. We should be doing UACRs, urine albumin creatinine ratios. And then EGFR of 60 to 89. Okay, there are folks that are like, oh, that's kind of normal. But see what happens as albuminuria gets factored in terms of risk. And then, of course, EGFR 30 to 59, you're like, well, even me as a cardiology PA, I can get that. I can figure that out. Yeah. But look what happens with albuminuria. And what that means is you should be intensifying ACE-ARBs or RAS inhibition. That means you should be thinking of adding finerenone or Kerendia as the brand, thinking of SGLT2s. If you haven't been, this is like, oh, okay, maybe I should do that. That's why we do this. UACR helps to really nuance the risk. And here's the KDI Go heat map. As we think about this, this is that same greater than or equal to 90, no albuminuria, but then boy, when you do a UACR and you see the event rates start to increase, even as normal as GFR 90 or better. Okay, so make sure that we're doing that. Here, when do we do it? When do you screen for UACR? Should I be doing this in all of my cardiology patients? Well, the current guidelines are really with diabetes. So as we kind of think about this, at least annually, and then monitor twice if they have any of these factors, high proteinuria or 30 to 60 eGFR, and diabetic. Here again, diabetes annually, and then you just kind of figure it out depending on whether GFR and UACR run, and then the KDO QI. Same thing here in terms of when to screen, the screening tests, and then the diagnoses. But remember, it's greater than 3 months of these being around that you can give the diagnosis. So sometimes it just, it comes up that an EGFR is like in the CKD range, but it has to be persistent. And so patients can be like, well, you never told me. I'm like, well, that was one. And then you see the next one, it's normal. So anyways, there you have it. What do we do with it? Well, I mentioned finerenone. This is Kerendia, and this is the Fidelio DKD study. They have the Figaro study, which is an exact flipped, same patients, same inclusion, but they looked at cardiovascular disease rather than looking at chronic kidney disease. And this is kind of similar, like, boom, you have a drop off in what happens with UACR. So placebo, they're like, they don't improve whatsoever. But in finerenone, it does improve. Here, I just wanted to show SGLT2s in terms of chronic kidney disease, and the data here is DAPA-CKD, there's EMPA, kidney, etc. So we know dapagliflozin or empagliflozin, both of them have been shown in the chronic kidney disease space, giving slide credit to Dr. Krause, of course. Here, I wanted to show GLP-1s. We've just shown the SGLT2s and we're like, oh yeah, cardiovascular or this. Well, the SELECT trial is specific to non-diabetics and benefit in cardiovascular outcomes. So BMI of 27 or greater, cardiovascular disease, no diabetes, using semaglutide reduces cardiovascular events, okay, by up to 20%. Here's the FLOW trial, which had to stop early because benefit. The DSMB was like, oh crap, people are doing really well on semaglutide, but they had diabetes and looking at chronic kidney disease. So please be comfortable with using these therapies. Common question. This was actually for primary care when I gave that talk.